Hello everyone, and I hope everybody is doing perfectly fine. So today we'll be discussing about molecular classification of carcinoma breast. So why this molecular classification of carcinoma breast is important? It is important just in few words, it is significant for treatment plan. So this is more patient oriented. So it will help it helps our clinician in much better way in managing their patients of carcinoma breast. So when we say, but first we should know about the pathogenesis for the development of carcinoma breast. So there are basically three pathways. So this is the mid one. In middle you can see there is breast with normal histology. So that is perfectly fine. So whenever their mutation occurs, so left and right arm, I'll tell you in detail what the mutation has been occurring in breast tissue. So if the breast tissue has BRCA2 mutation, BRCA2 mutation, along with that, if the patient is having 1q gain and 16q loss, so that results the tissue will get converted to your ATPR. And above that, if the patient is having this PIK3CA mutation, patient will develop atypical ductal hyperplasia, which will in turn go into pre-invasive malignant condition, that is your ductal carcinoma in situ. So then this will also develop into frank invasive carcinoma breast. So similarly, we can see this pathway is ER positive pathway. So then next we take the right side pathway. Here what happened, we are seeing the normal breast is undergoing BRCA1 mutation. After that, patient is having TP53 mutation and there is inactivation of your BRCA1 gene. So that also leads to your ductal carcinoma in situ, which finally lands up in your invasive breast cancer. So see in between what we saw in center, then third pathway. So this is your ER negative pathway. So this is having a worse prognosis. So in between what is there? There is TP53 mutation, HER2 new amplification. So this middle one pathway is your HER2 new overexpressive pathway. So here what happened, there is patient will develop atypical apocrine adenosis and patient will ultimately land up in ductal carcinoma in situ. So this will also frankly go into invasive carcinoma breast. So left is your ER positive pathway. This is your ER, right is your ER negative pathway, and the center one is your HER2 new overexpression pathway. So this ER negative pathway, that is the breast जो type of carcinoma होती है, that is your basal like, fine. In between you are getting is your HER2 new overexpressive one, and the left is your luminal type. So now we'll go into the different 5 types of breast cancer on molecular basis. So we'll describe in short. So first when we saw the luminal A and luminal B, it follows your ER positive pathway and the normal like third one also, right? So these three have better prognosis as compared to other type of malignancy. So luminal A. So when we go for the hormone, this is ER positive, PR positive, HER2 new and Ki67 is negative. So Ki67 is a proliferating marker, so that is negative. 50 to 60% it accounts for. See, luminal type together, luminal A and B. So together they account for 50 to 60% of all breast cancer. उसमें 24% जो होती है वो है luminal type A और 50% जो होती है that is your luminal type B. So now we know luminal A Ki67 is negative, so low mitotic activity. So there is a controlled cancer growth. But here luminal B, it has ERPR positive, same है luminal A की तरह, but it can be HER2 positive or HER2 negative. Ki67 is positive, so it is more proliferating. So comparatively the growth is much faster as compared to luminal A, and prognosis is bad as compared to type A. So treatment, when you consider, there is endocrine therapy you can give for luminal A alone or with chemotherapy. And now luminal B, as HER2 is also positive or negative, so along with endocrine and chemotherapy, you can give anti-HER2 new therapy. We can give or we cannot give. We may not give depending on the HER2 new status. Then the third one, which is your normal line. Here also you have ER, PR positive, HER2 new and Ki67 negative. It is morphologically and hormonally it is much similar to your luminal type A. It accounts for 8% of all breast cancer and it has a genetic makeup that is similar to your normal breast. So it has, as we know, this has genetic basis similar to the normal breast. So, but prognosis is bad as compared to luminal A. So, luminal A has the best prognosis, and luminal B and normal like it also it has this morphologically it is similar, in hormonal it is similar, but there are certain differences as we have discussed now. So, they have like worse prognosis when you compare it with luminal type A. And treatment in this category is endocrine therapy alone or with chemotherapy. Then coming to HER2, the fourth type, it's a HER2 new overexpression. Here it is ER/PR negative. So that is to be remembered. It is HER2 positive. It accounts for 10 to 15% of all the cancer breast. Growth is faster than the luminal type, but the targeted therapy against this your HER2 new positivity, so that like Herceptin drug can be used. These are useful. So this malignancy, this fourth type, so it has hormonal basis and can be the patient can be given hormonal therapy. So treatment is basically against the amplification in favor the overexpression of HER2 receptor. So treatment, the basic principle for the treatment is that so though it grows faster than the luminal type, but due to this targeted therapy, patient can be given hormonal treatment. So here chemotherapy with anti-HER2 new therapy can be given. Then fifth one is your basal-like type. So this is the type with worst prognosis. It is also known as your triple negative. ERP or HER2 new negative and basal markers are positive. It accounts for 15% of total cancer breast and it is associated with BRCA1 and P53 mutation. It has worse prognosis as I said, and treatment has to be most aggressive one, and this has highest association with BRCA1 mutation. Chemotherapy is the treatment of choice for this. No hormonal therapy can be given to the patient. So thank you so much for your patient hearing. Kindly like, subscribe and share my channel Patho with MK.